Management of atrial fibrillation. If duration of atrial fibrillation is less than 48 hours, that is new onset atrial fibrillation, and the patient is hemodynamically unstable, then we have to do immediate electrical DC cardioversion with 100 to 200 watts per second of shock therapy. Along with this, we have to give heparin and warfarin to maintain the INR 2.5. International normalized ratio 2.5 is achieved. Then we can stop the heparin, and warfarin should be continued for 4 weeks. If this is the first episode and patient doesn't have any underlying conditions, can stop the treatment. No antiarrhythmic drugs need to be given. If the duration of the atrial fibrillation is unknown or more than 48 hours and patient is hemodynamically stable, go to transesophageal echocardiography and see if there is an clot or intracardiac emboli. If we find emboli, then we do not cardiovert the patient, or if there is no emboli, do electrical cardioversion. We have to give heparin and warfarin until the INR is 2.5, and later we can stop heparin and continue with warfarin for 4 weeks. And if the patient has high risk for recurrent atrial fibrillations, or if there are persistent atrial fibrillation due to heart disease or without heart disease, based on that we will continue the antiarrhythmic drugs. The antiarrhythmic drugs can be classified as BCD, like beta adrenergic blockers, calcium channel blockers, and D is for digoxin. So patients with heart disease like coronary artery disease, hypertension, and left ventricular hypertrophy, we give beta adrenergic blockers, sotalolol. But patients with COPD, we have to be careful and choose alternative options like calcium channel blockers, diltiazem. If the patient has congestive heart failure or cardiomyopathies, we have to choose amiodarone or diltiazem as options, and digoxin. Digoxin has rapid onset of action, but it cannot be used in a patient or exercising. So in that case, we have to choose diltiazem. It is IV diltiazem has better action in active or exercising patient. Patients without heart disease having atrial fibrillation, we can use flecainide, propafenone, and diazopyramide. According to American College of Cardiology and American Heart Association, new guidelines use novel oral anticoagulant agents to prevent thromboembolic episodes. So these are dabigatran, rivaroxaban, apixaban, edoxaban. These novel oral anticoagulant agents should be used with caution in patients with hepatic and renal dysfunctions, and these hepatic and renal functions should be constantly monitored, at least annually. And these agents are more preferred to the warfarin use, because warfarin we have to monitor INR frequently, which these novel oral anticoagulants need not be monitored, but these are short acting. These novel oral anticoagulant agents cannot be given to patients who have moderate to severe mitral stenosis or patients who have mechanical heart valves. And these novel oral anticoagulants are preferred with CHAD-VASc score of greater than 2 in males and greater than 3 in females. CHAD-VASc score is congestive heart failure, hypertension, D for diabetes, like vascular diseases, previous sorts of stroke, and age greater than 75 is the CHAD-VASc score. So if that score is greater than 2 or in men or greater than 3 in females, then novel oral anticoagulant agents are preferred than warfarin, because warfarin needs to be continuously or frequently monitored with INR levels. In patients with underlying causes like thyroid, electrolyte abnormalities, infections, pericarditis, myocarditis, cardiac structural abnormalities, we have to treat the underlying causes. And in Wolff-Parkinson syndrome, we can do catheter ablation, either radiofrequency ablation or cryoablation procedures. And also those with non-vascular atrial fibrillation with embolus in the left atrium, they having a procedure, percutaneous left atrial appendage occlusion procedures. In patients who are refractory to antiarrhythmic drugs or who are intolerant to antiarrhythmic drugs, catheter ablation is useful along with permanent pacemaker. And in atrial fibrillation patients who are undergoing other cardiac surgeries also, catheter ablation is useful. This completes the management of atrial fibrillation. Thank you.